Hello there, my name's Jasmine and I'd like to welcome you back to another CPD talk. So today's talk is going to be on neonatal, paediatric and adults, which components we should be using in each scenario. So, for the purpose of today's presentation, there is a worksheet on QPulse. Before all of this starts, and I will pause the video at that point, I would like people to attempt the first section of the worksheet, and I'll go into that in a bit more detail in a moment. We're then going to go through the definitions of neonate, paediatric and adult, why these can be confusing and the reasons for those definitions. Then we'll move on to the different components that are available, and this is basically what is available for us to order, how they are different and when we should be selecting each one. I'm then going to go into why the use of mils when dosing blood is the golden standard, especially in low weight patients. And then we're going to go through a case study of how selecting the incorrect component could have negative impacts on the patient, how we should be applying this knowledge to our practice, and then I'm going to go through acknowledgements and end the presentation. So let's get started. As I said, I would like everyone to attempt a worksheet alongside this. The document number is in the description box below and you can find it on QPulse. Section 1 is for you to answer based on your own background knowledge, and then section 2 is to come back to later on, and again I will let you know when to do that. So if you pause the video here and go and get that worksheet. Right, so hopefully you've done that now, and we're going to move on to the definitions of each of the terms in the title. So, when we're looking at these terms, most people have a predefined answer for what they think each term means. However, it's important to note that depending on where you work and what you're using as a reference, there will be different definitions of these. So, if we start with neonate, for example, according to BSH guidelines, so that's the British Society of Haematology, where a lot of the laboratory guidelines come from, a neonate is defined as a patient that is 28 days of postnatal age. So that'll be up to 28 days. But then if we have a look at our laboratory specifically, and again this will vary between laboratories, we say it's a patient that is less than 4 months of age. And according to the hospital, again, so this is Medway Maritime Hospital, based on ward admission, you're either looking at a patient who is less than 34 weeks of age or less than 1.6 kilograms. So you can see there's quite a big difference between these, and I'm going to discuss them further in the next slide. If we then move on to paediatric, again, according to BSH guidelines, there's not actually a definition in there for paediatric, and they have a extra definition. So they have a term called infant, which is a patient that is over 28 days of postnatal age, but less than a year of age. Based on that definition and their definition of adult, we can assume that paediatric to them is a patient that is over a year of age, but less than 18 years old. It's very interesting that they have a patient category for infant, because if we then go into the terminology used in our laboratory, paediatric is going to be a patient that's greater than a year of age, but less than 16 years old. So you can see we're missing a time period there. That's the greater than 4 months, less than a year of age. And again, I'll explain that further in the next slide. And according to the hospital, a patient who is a paediatric patient is basically anyone who is less than 16 years of age. An adult. So according to BSH guidelines, as I mentioned before, they recognise adults as patients that are greater than 18 years of age. However, they do recognise that some hospitals treat adults as patients that are greater than 16 years of age. And that's what our hospital and our laboratory does. And that's Medway specifically. At Dartford, they may have different rules in place. And again, within your own hospitals and laboratories, it's important that you're aware of these because it will affect what components you might give the patient. If we have another look at these, I'm going to leave the adult definitions as they were because, to be honest, if we had having a look at them, they pretty much line up spray. Although BSH guidelines say 18 years of age, they do have the caveat that some hospitals will use 16 years. So we can say that they're on the same page. The places where there was the biggest difference was between neonate and paediatric. So if we start with neonates, in the laboratory, we specifically say less than 4 months old, and that is for several reasons. Firstly, babies don't start creating antibodies until they're 4 months of age. Therefore, it's at the 4-month point when we can perform a full group and antibody screen, because a full group will look at the forward group, which is looking at the patient's antigens, and a reverse group, which is looking at their antibodies. So there's no point in us doing that when they're less than 4 months and don't create any antibodies. Because of this, we would then conform to guidelines to have 2 samples taken at 2 separate times, and we would give the patient group specific blood. So that is a blood group that is matching their own blood group. In general, laboratories will follow the rule that if a patient is less than 4 months of age, we will give them O negative units, and that's just for the safety of the patient, in case their forward group is not actually representative of the blood group they've got. There are several reasons for that have been mentioned in a different presentation about anonymous blood groups, so I'm not going to go into that here. So you can see why in the lab we're looking at patients that are less than 4 months old. So if we move on to paediatric patients, within our trust we have the less than 16 years of age, and that's important specifically for our trust because our trust guidelines requires all patients who are paediatric to be given irradiated and CMV negative blood components. This is not standard procedure across the UK, but has been implemented at Medway because a lot of our children who have transfusions are immunocompromised. So it was there as an extra layer of safety because it doesn't harm a patient to be given irradiated products, but it will harm a patient to not receive the irradiated products if they require it. If it was an emergency situation, however, and we didn't have the products available that were irradiated, then we would review this requirement on a case-by-case basis. So just from that, you can see why it's important to know what the different definitions are depending on where you are. If I was in a different hospital, they might say that an adult is anyone above the age of 18, and they might not actually have a requirement in place to give irradiated or CMV negative blood components. It might not actually have any relevance to us whatsoever. But in our case, it is important for us to know what patients are paediatric and what patients are adults. So now that we've reviewed the paediatric policy, we've said that a paediatric patient is someone who is less than 16 years of age, and a neonate is someone who is less than 4 months. We would, for the most part, in terms of blood, so that's red blood cells, we would call the patient a paediatric patient once they were greater than 4 months old. However, when you're looking at other components such as FFP and platelets, we might give them neonatal components. They would just, FFP no, but the platelets would just have to be irradiated, and that's just for the quantity involved, because you're going to have a smaller volume for the neonatal units and therefore less wastage. We would have to switch to the paediatric procedures because they need to be irradiated once they are greater than 4 months old to fall in line with the trust procedures. So moving on to what blood components are actually available for us to order. I haven't written out the whole list because some of them are very similar to each other. So I've basically selected the units that are important to do with the different sizes and the different requirements between patients. So if we start with red blood cells, you've got IUT red blood cells, and that stands for intrauterine transfusion. Neonatal red blood cells or pediatric packs. LVT, which is large volume transfusion red blood cells, and then normal red blood cells. FFP, you have FFP for neonatal use and just adult FFP, and the same with platelets, you have neonatal platelets and normal platelets. I would like to add the caveat that you have the ability for platelets and red blood cells to have irradiated products. There are also exchange ones and more specialist components, but as that's not the purpose of this talk, I'm not going to go through them in much detail. So, what are each of these components? Start with the intrauterine red blood cells. These are irradiated on request and are then only valid for 24 hours. The donors must have donated several times previously, and that's to make sure that all of the testing has been repeated on a couple of samples to ensure that they definitely don't have any diseases. There'll be CMV, HBS, and K negative, and should be compatible with the mother and therefore the baby. So if possible, we will choose O neg, K neg, and negative for any antibody specificity required. However, it will depend on the specific cases. Neonatal red blood cells or paediatric packs are the ones that confuse people the most. On the website where we order blood, they are called neonatal red blood cells. However, in the lab, I assume for a historical reason, we often call them paedi packs, and that's just, it sounds better, right, with the alliteration. It's important to note these are not intended for paediatric use. They are intended for neonates. They are small volume, normally only 45 mils, still CMV neg and HBS and K neg, but not irradiated routinely. And most hospitals will order them as O negative units only. I will go through why it's important to be aware that they are for neonatal use only later on. You've then got large volume transfusion. These are normally still used for neonates, but only for very specific circumstances, such as ECMO or for other cardiac reasons. So they're not routinely used, and it will be reviewed on a case-by-case basis. And finally, you've got red blood cells, which are just for adults and for paediatric use. So in our hospital, we would choose irradiated red blood cells for paediatric patients. So FFP and other frozen components. For neonatal use, again, the donors have undergone the extra testing. They will be leukodepleted and originally were methylene blue treated, but this is no longer done. They're normally used up to 1 year of age. So this is one of the components that I was talking about, where although they say they're for neonates, they overlap into the paediatric section a bit. And that is just because they're a smaller volume, so there's less wastage. And because there's not really that much difference between the not for neonatal use ones. These will still be leukodepleted, although the donors could be first-time donors. And they're just going to be a larger volume. So that's why it's okay to use them up to 1 year of age, because there's not that much difference between the adult and the neonatal packs apart from volume. Platelets, we've got neonatal platelets and routine platelets. So neonatal platelets, they're normally apheresed, they're a smaller volume, they're CMV negative. It says they're HEV negative, all components are now HEV negative, so that's redundant. Platelets for adult and paediatric patients. So apheresed platelets can be selected if the patient is a paediatric patient, and then pooled platelets are also available. So looking at this in more detail, IUT red blood cells, they're for fetal use, so that's when the mother is still pregnant with the child. It is a transfusion that's happening in utero. Neonatal red blood cells or paedi packs are for neonates only, as I mentioned before, and red cells are for adult and paediatric use, and the requirements that you associate to them will depend on your hospital policies. FFP and frozen components are, so the neonatal use are, again, they're for patients less than a year of age, and not for neonatal use, they're for patients who are greater than a year of age. In terms of the platelets, the one thing I want to clarify here is the difference between apheresed and pooled platelets. Apheresed platelets come from one donor, so that's the patient that's gone in specifically to donate platelets. So they use a specific machine that will, although they will take out blood, it'll filter through the platelets and they'll be taken out separately, and the blood goes back into the patient's body, and then they can get a donation or two of platelets direct from that patient. A pooled pack of platelets is one that has come from between 3 and 5 donors, and that's where a patient has donated whole blood, and as part of the filtration process you don't get enough platelets for a whole bag of platelets, you have to pool several donors together, and obviously testing will be undergone to ensure that all of the patients are the same blood group and have the same requirements. The reason that we select apheresed platelets is because it's less donor exposure, and that's something I'm going to talk about more later on, but where we can, we try and avoid donor exposure as much as possible for neonatal patients and for children. The more donors you are exposed to, the higher the risk is that you're going to have a transfusion reaction or create antibodies, or basically that there's going to be a negative effect. However, there's a lot of controversy surrounding this, so depending on what hospital you are in, the policy will differ. The reason for this is, in an apheresed pack of platelets, although you're only getting it from one donor, you're going to get a lot larger volume from that one donor. Therefore, there could be a higher risk of there being more red blood cells there causing a reaction. Whereas with a pooled pack, although you are being exposed to between 3 and 5 donors, the chances are you're going to have such a minute amount of red blood cells in that donation that it shouldn't cause any reaction for the patient. There's a lot of controversy around that, but depending on your hospital, you should follow the protocol there as to whether you should be selecting apheresed or pooled platelets for neonates and paediatric patients. So, we've gone through all of that basic background of the definitions, the different types of blood components that are available, and which we use for which patient. If you could go back to your sheet and complete section 2, that would be great. So if you pause the video now. So we're now going to move on to why dosing in mils is the gold standard. So when doctors and clinicians are prescribing or ordering blood components from us for a younger patient, they should always work out the amount that is required based roughly on the patient's weight. This is to prevent the patient from being overloaded and having unnecessary transfusions, which could cause adverse reactions. As we previously discussed, sometimes the names of components can be misleading, so with the paediatric packs being for neonates and not paediatric patients. If you are given mils in the laboratory, it will give a better idea as to how much is actually required for the blood component. The other thing to note is that whenever blood is transfused, some of this will be lost in the giving set. So if someone requests dead on 45 mils, you need to ensure that they've taken into account that up to 9 mils of this will actually be wasted and not transfused to the patient, as they may actually require 2 packs instead of 1. So depending on how much of an increase they need for that patient's hemoglobin will depend on whether or not they do want to split it into having 2 packs, or whether they will be okay with that 45 mils. The other thing will be, depending on how they've been taught to do this dosing, they may have already compensated for that. So they may have already added on that wastage into that when they're ordering the blood from us. So it's important to ask whether or not that includes the wastage. I'm going to go through an example from a case study that was presented during a Transfusion Bites talk recently that I know not everyone was able to go to. In this case, the ward rang up the BMS in the lab and requested 190 mils of an adult unit for a child. This was a rather small child, and the clinician looking after the child was worried about fluid overload, which is one of the risks of transfusing too much blood to a patient. So asked if she could have this as 4 paediatric packs instead of 1 unit. Although the BMS was aware that this was not the correct procedure, they okayed this. This was more down to the BMS's confidence than anything else. Unfortunately, at this hospital, they only had 2 paediatric units in stock, so they had to order more in. This then meant that the child had to stay overnight without her parents, and that she was unnecessarily exposed to 2 different donors, one from the 2 paediatric packs that they already had on site, and one from the paediatric packs they ordered in, instead of just 1 donor. Further to this, because an adult giving set was used to give the units, which meant that up to 20 mils was wasted with each unit, At the end of the transfusion, the patient had only actually had around 100 mils transfused. Obviously very negatively impacted the patient. They haven't been transfused the right amount of blood. They've been made to stay overnight when they shouldn't have. They've been exposed to extra donors, which could cause the formation of antibodies and has extra risks embedded in this scenario. And because the clinician didn't understand about the wastage, they used an adult giving set. So what can we learn from this? In case people aren't aware, the machines that are used to transfuse blood components can be set to transfuse a specific amount. So this patient could have been given an adult unit and the equipment would have stopped the transfusion when it hit the correct amount of mils. And this would negate the risk of TACO as long as the equipment is correctly set up. If they had been given the adult unit, they wouldn't have had to stay overnight. They would have only been exposed to one donor and they would have been transfused the right amount of blood. Not only that, but we wouldn't have used up precious neonatal units which could have been given to other babies. So it's important that we keep up to date on current terminology so that we can correctly inform clinicians about blood components, so that we have the confidence to question and explain why we follow the procedures that we do. Luckily, this patient was fine. All of this could have been avoided if the BMS had explained what the risks were associated with the components and had the confidence to discuss the case thoroughly with the requester. So hopefully this has been an interesting talk, and even if you haven't learned anything new, it has solidified knowledge that you're already aware of. I'd like to thank the Transfusion Bites talk that occurred on the 7th of October, as it had a case study. It had the case study in it that highlighted the issues surrounding the use of paediatric blood incorrectly, and you can find a link to the recording of this talk in the description box below. Once you've completed your worksheets, if you send them back to me and complete a reflective learning, I will mark them and I will give you a certificate to show that you have completed the CPD talk. Thank you ever so much for listening, and I look forward to the next one. Bye!